It's my pleasure today to moderate this session about what are patient organizations doing to enhance inclusion, research, and outreach. I am the Chief Science Officer for the Marfan Foundation, and I am very excited to moderate this session with my colleagues from two National Health Council member patient groups that have a unique position in their organizations. We are thrilled to have them share their successes and their challenges with inclusion research and outreach at their organizations. The first speaker is a first-generation immigrant, Adrian Palau-Tejeda, grew up in Madison, Wisconsin, watching his father make signs for community organizing and listening to the stories of rallies and marches. Working with the underserved communities throughout his university years, including field organizing in the South Side of Milwaukee, Adrian has devoted himself to a lifelong mission of serving the underserved and underrepresented. In his position as Diversity and Inclusion Fellow, Adrian is committed to increasing the EveryLife Foundation engagement with underserved rare disease communities, creating resources and tools for patient engagement, and partnering with rare disease organizations in the rare disease space. Our second speaker will be Jeanne Regnante, and she is the Chief Health Equity and Diversity Officer at the LUNGevity Foundation and has worked in healthcare advocacy for more than 35 years. Prior to joining LUNGevity, Jeanne served as the Senior Vice President of Community Engagement for National Minority Quality Forums for the Sustainable Healthcare and Equity and Chair of the Diverse Cancer Community Working Group. She is a founding member of the Patient-Focused Medicines Development and a co-leader for two EU Innovative Medicines initiatives focused on standards for patient engagement in medicines and development. Jeanne recently co-founded and launched Patient Insights Inspire Innovation Program, Patient 3I, which is positioned to transform the global patient engagement framework by focusing on the patient as the expert. So now we'll turn it over to Adrian.
Great. Hi, my name is Adrian Palau. I'm the Diversity and Inclusion Fellow with the EveryLife Foundation for Rare Diseases. Next slide. And really, before discussing our efforts in diversity and inclusion, I'd first like to frame the conversation around what are systemic barriers and challenges faced by underserved communities. It's firmly my belief and the belief of the EveryLife Foundation that we have to understand the barriers and challenges to the rare disease community in order to engage and empower them. So next slide. So when engaging with underserved communities, we have to understand the barriers and challenges that exist systemically and in provider spaces before really committing to talking, speaking, and empowering these communities. You really can't engage a community if you don't understand these struggles that they are going through. So challenges to diverse communities, underserved communities include systemic discrimination, cultural barriers, lack of representation in rare disease spaces, lack of diversity in clinical trials, lack of community health providers, unconscious provider bias, language barriers, and more. These barriers exist throughout the space of health services, throughout society as a whole. And they exist and the consequences of these challenges are in fact in everyday life for underserved communities. Next slide. So what are the consequences of these challenges? Well, what's the impact on everyday life for underserved communities? So according to a 2018 presentation by the MRTC Center, we just presented a little bit earlier, participation by Black or African Americans in cardiovascular clinical trials was about 3%. In oncology clinical trials, it was again 3%. Now, this is despite the fact that African Americans make up 13% of the total population in the United States. If we look at, diseases and inherent risks for Black or African Americans, we see that African Americans have almost twice as likely chance to develop prostate cancer. Yet they only represented, again, 3% of prostate cancer clinical trials. Despite making 6% of the population, Asian Americans only represented 1.7% out of a total of 70% of clinical trials. If we look at the story of clinical trials in the United States and the research towards novel treatments, we see a continuous story of a lack of inclusion in the research space of underserved communities. This is as a consequence of historic and systemic disenfranchisement. Now, what does this look like in the provider space? So next slide. So in a study published in the Academic Emergency Journal, we see that women waited on average 16 more minutes in the ER before being administered opioid painkillers than men for acute abdominal pain. Now, this is to represent and show how provider bias can impact the administrance of medicine in an emergency situation. Now, when talking about rare disease patients and the process by which rare disease patients go to be diagnosed, we refer to it as the diagnostic odyssey. Now, it's an odyssey because it's not straightforward. It's not a simple process of going to your healthcare provider and receiving a diagnosis. Yet for underserved communities and underrepresented populations, the process is even more muddled. It's even more of an odyssey because of inherent provider biases and biases in the space. Really, before engaging with underserved communities, we have to understand these biases, these inherent barriers, in order to really create strategies and listen to communities. And this really goes into the EveryLife Foundation mission. Next slide. So the EveryLife Foundation for Rare Diseases is a 501c3 nonpartisan organization dedicated to advancing the development of treatment diagnostic opportunities for rare disease patients through science-driven public policy. Now, what does this mean? We are a patient empowerment foundation. It's patient-led, it's patient-first. We do not speak for patients, rather we create avenues for patient voices to be heard. And really, in order to hear someone, in order to empower someone, you have to know about the systemic challenges facing them. Next slide. So how do we do this exactly? How do we actually engage patient advocates and how do we empower them? So we do this through a series of events and programs at the EveryLife Foundation. One of the chief among them is Rare Disease Week on Capitol Hill. Bringing together hundreds of patient advocates onto Capitol Hill, we seek to create avenues for patient advocates to engage with legislators at the highest level of governments. Really, the aim is to create a space where patient advocates are the center focus for policies that impact them. And that's really where diversity and inclusion comes in, because we want to make sure that our programs are reaching as diverse and underserved communities as possible. Next slide. And we do this by creating spaces at events for diverse community focus. We do this by planning how to best use our scholarship and stipend programs. As an organization, we have programs in place designed to help alleviate the burden of traveling across the country, of taking time out of your everyday life to attend an event. It's our understanding that rare disease patients don't have an infinite amount of time and don't have an infinite amount of opportunities. Their time is valuable, and we seek to help make sure that the patients that arrive at our events are doing so with the most focus on them as possible. Additionally, we're working to increase outreach to states with diverse patient populations, performing outreach to diverse populations and rare disease organizations. Really, this means engaging diverse and underserved communities where they are. So if we understand diverse communities, we understand the challenges facing them, we also have to go to where these individuals are and the organizations that they're a part of to empower fundamentally diverse and underserved patient advocates. Additionally, creating resources and models, really focusing on a cooperation-focused approach. It's more than simply outreaching to diverse audiences, more than outreaching to underserved audiences, but rather being participatory and cooperative. We simply cannot advocate for just speaking to underserved communities, but rather engaging with them and bringing them in such a way that they are empowered. Next slide. Strategies for inclusion for organizations realistically include developing a diverse board and staff that includes underserved communities. You cannot engage with underserved communities if you do not have members from them in your organization. By enabling feedback from diverse communities, we also make sure that our programs are kept honest to the needs of underserved communities and make sure that they actually are achieving what they're set out to do. By setting quantifiable goals for inclusivity and diversity, we make sure that we're on track to developing an inclusive space. And by offering multilingual language options for event and project materials, we make sure that we are reaching English limited audiences. At the end of the day, the end goal of this presentation, and this should be, how can we engage meaningfully with underserved communities in such a way that it's not simply reaching out to them, but rather working with them? How can we join together with underserved communities and realistically create a better future together? Because it should be participatory rather than simply speaking to. Next slide. Thank you so much. It's a great opportunity to speak in front of everyone, and we're on this together.
Hi, the next speaker will be Jeanne Regnante.
Okay, thanks everybody. Can you hear me?
Yes, we can.
Yes.
Okay, thank you. Okay, so before I start, I just want to compliment Adrian for the great work that he does for the EveryLife Foundation. You know, working with patients, diverse populations to advocate for their disease and aspects of their care that matters. And I really think that Adrian shows the power of what one person can do. So in this space, which sometimes is hard, but we need to be brave. So next slide. So before I start, I wanted just to share a bit of how I got there. There's a lot of pictures on this slide. I've been inspired by friends and leaders over my career who, in the fight for health equity, focus on actually doing something and modeling action versus admiring the problem. So several leaders on the slides here are at the National Health Council, and my past and present managers, two of whom are past and current National Health Council board members, like Mike Rosenblatt on the lower left, and you see Gary Puckering in the car. We're all packed in on the right. And I do want to mention somebody in particular that has really influenced me. So my dad is on the middle of the slide on the bottom, and he just celebrated his 92nd birthday on September 5th. And he's still working. He was the first patient advocate I knew. Back in the 1980s, a story that my family often talks about is that he wrote a letter to the White House on a yellow legal pad asking Nancy Reagan if she would bring back 2 kids from South Korea on Air Force One. These children needed heart surgery urgently at his hospital, and he then got a call from the White House, and the kids got to ride free. And that was the start of the Gift to Life program where he's a founder, where Rotarians all over the world saved the lives of 200,000 kids worldwide who have congenital heart defects. He's now saving veterans and helping them get access to much needed healthcare on Long Island. And he just last week raised money for another medical transport van. So I really have been surrounded by people and leaders in my life who do it and not just talk about it. and not just talk about the commitment that they have to health equity and diversity. They actually do it. And I have been inspired by them. So what I wanted to do is share my plan with you on what we're doing at the foundation, the decisions that we've made, and our actions and our plan. And I thought maybe this might inspire other patient organization leaders or industry leaders to be in this fight with us together. Next slide. So our goal at the LUNGevity Foundation is to improve the lives of all people impacted by lung cancer. We actually did just update our profile as an organization. Historically, because of how the LUNGevity Foundation began, our focus and engagement has been on high socioeconomic white populations and has included never smokers. So like a lot of patient organizations in terms of how they start with a lived experience, Andrea Ferris, our CEO, started LUNGevity when her mom, a never smoker, died of lung cancer, and she realized that there were no resources for people and families like her. So right now, what we know is that lung cancer has the highest mortality of all cancers and more deaths than the next 4 highest cancers combined. But what's really amazing is that there is so much hope for patients diagnosed with lung cancer. Many people are living with lung cancer longer. You might even know someone. There have been 22 new FDA-approved innovations for lung cancer in the last 4 years. Mostly targeted therapies, and they're clearly not getting to all the people. Many patients in vulnerable communities tend to be hopeless, fatalistic, unengaged, and underinsured, and therefore early detection and their care and outcomes greatly suffer. And there also hasn't been a lot of funding in lung cancer historically, so community outreach partners, NCI comprehensive cancer centers, the funding for research, education has been minimized, if you will, but I think it's on the rise, and that creates hope for all of us to make a difference. So an action for us with respect to the plight of patients and where we are as an organization. We do have an organization of 34 staff, and we made a decision to amplify their current work, and we will address gaps and must have new capabilities. So they will be, with the work that they do, including diverse and underserved populations with the work that they do. We also added several board members who have focused their careers on addressing disparities, including Dr. Robert Wynn, who is the first African-American head of a comprehensive cancer center in the US. He's based at Virginia Commonwealth University in Richmond. Next slide. So this quote came out of the chat function at our International Survivorship Conference that we recently held, where we had 1,200 patients and caregivers attend. And we were successful in having many more diverse populations than we've had in the past attend this conference through our community partnerships. So this known lung cancer survivor said, wow, I really had no idea there was an issue with African Americans not being included in a lung cancer clinical research. This was really memorable to me because this woman had no idea that there was an issue with African Americans not being included in clinical trial. And we know that ultimately the power is in the patient's hands, as Adrian explained. If patients don't understand the standard of care and hope that there is for them, then they don't know to advocate for themselves. So for our action, and a decision that we've made, is that we must make sure that patients understand the standard of lung cancer care and advocate for it. We can't count on, for example, all eligible patients to be included in clinical trials and to be asked automatically by investigators. We need to reach patients and encourage them to ask for clinical trials as an option for themselves. So next slide. In the work that I've done since I started in March, I really continued to learn from patient organization leaders who have engaged vulnerable populations with success. And the Prostate Health Education Network is an organization who partners with faith-based organizations, 1,000 organizations around the country, to ensure trusted, sustainable engagement and education for African-American men at risk or who have prostate cancer. This is an example of what a patient organization that does it actually does. They don't talk about their commitment, they do it. So an action for us as a foundation is that we must constantly look to engage other patient organizations who are engaging vulnerable populations so we can learn from them. Next slide. I mentioned that we will not create a shadow organization to focus on disparities in lung cancer, but we're going to amplify the work that we do across functions at the foundation. So what do I mean by amplify? So what we've done is we've conducted ongoing awareness and education of the staff and discussed definitions, the language of health equity and disparities in lung cancer care. And we have conducted what I call What Matters training on an ongoing basis. And through this training of the staff, they've really given me feedback on what we should focus on and what the gaps are. And an action for me is to listen to them. Next slide. This is a BMS Foundation slide, which I feel like I carry around in all my presentations. It's a great slide. It basically shows national data for African Americans and lung cancer. And it basically shows that throughout the cancer continuum of care, some attributes that are important to note. First, that African Americans get treated later, they present with later stage disease, they wait 5 times longer to see an oncologist, they get biomarker testing less, which basically hurts them from getting newer, more innovative treatments. And overall, the 5-year survival for African Americans are 20% less than for white American. So the disparities across the continuum of care for lung cancer are not the same from population to population. So for example, if you look at Asian Americans, they often get biomarker testing. Why is that? We need to understand that. We need to understand why Asian Americans get biomarker testing and why African Americans do not. So here's a decision that we've made. We've decided that we must be expert in lung cancer disparities across the continuum of care year to year at a national, state, and county level for 5 major demographic populations compared to high socioeconomic whites. We need to understand those differences and those disparities. So this is a new capability that will help us target and address disparities in communities across the US so we know that we're making a difference. And I want to just quote my old boss, Gary Parkerin, who has always told me, and I agree, that one can't move what one can't measure. So there's a gap. We need to do it, and we need these data. Next slide. So we've talked about historical injustices for the population that we wish to engage. We do this as a staff. We feel that empathy drives understanding. We have spent a lot of time at the foundation discussing these injustices. So the Tuskegee study is important to know about and think about how this injustice in healthcare could have happened and why it can never happen again. We also have learned about Henrietta Lack's contribution to medicine, which she or her family never consented to. We need to understand as a foundation, and the staff needs to understand this, and they're starting to wake up to the fact that there is lack of trust in communities because historically patients have not been respected or asked what they think. So our action is that we will never blame patients for their lack of trust or fear that they have. And Adrian mentioned this, and it's so important, that we must engage them where they are with trust and respect. Next slide. Next slide. Thanks. So we are addressing implicit bias in our organization, even though the government has decided not to do this. This is how we model cultural humility. We have conducted training, partnering with Results One, a great organization in Washington, D.C., to introduce our entire staff to implicit bias awareness training. The training was memorable, quite successful. The trainer was exceptional. The goals, methods, and outcomes were submitted as an abstract to the American Academy of Cancer Research meeting actually next week, and it was accepted. The staff wants to do a part 2 training which expands on their own awareness and focuses on their own biases and help them to have an individualized plan. And I would really encourage others to think about doing implicit bias training for their own organization. Next slide. So when engaging the staff, I always have felt that our priorities and the answers and the gaps that we have as an organization to better engage racial and ethnic minority populations and underserved populations must come from them. And this is what they told me. We need to have a commitment to an expanded patient definition. We need educational materials that make sense. Our materials are too complicated, they're not culturally sensitive or health literate. And a community engagement. We need to develop a community-based organization network. We need connectivity with trusted leaders in high-risk communities who are engaging with vulnerable populations. So we have a need to better define our vulnerable lung cancer communities and what we mean. So what we mean by our communities that we need to serve better are racial and ethnic minorities, people with disabilities, people from rural communities, the LGBT community, and immigrant population. And it's important that we also think about and engage patients where they live. The footprint for lung cancer across the United States, population to population, is different. And we need to pay attention to geography. So geography matters. And on the map on the right shows where African-American beneficiaries who have lung cancer live. So it's important that we focus on California and Texas and the Northeast and North Carolina and Michigan and Indiana with intensity when we work with our partners to reach patients in a way that's thoughtful and respected. So next slide. So let me just talk a little bit about health literacy. One of the things that we did is we did a pretty big environmental scan to look at patient education materials for patients with lung cancer, to look at the degree to which they are health literate and available in the United States. And we found a study which was quite alarming. It was done by University of Illinois. They conducted a study in late 2018 looking to the degree to which patient education in lung cancer screening was health literate. And they couldn't find any public information that was health literate. So we at the foundation realized that we have a clear gap with providing health literate education to patients. And our patient materials, education materials are excellent, but they're quite scientific and not written with health literacy principles in mind for the populations that we wish to serve. And we also know that health literacy is an enabler to engage patients with their healthcare providers so everybody understands each other. So what we've decided is that we need health literate, culturally sensitive, and linguistically appropriate educational material that is tested by patients and delivered by experts who do this work. So we're currently working with a health literacy expert organization to put a process together with us to develop health literate information for patients across the cancer continuum of care. Next slide. So just to expand on this concept, what it takes to engage communities is the community. So how are we going to do that? How are we going to do that at the LUNGevity Foundation? So there's 3 individuals on the slide. Ricky Brower from Jefferson University, Lorna McNeil from MD Anderson Cancer Center, and Kareem Watson from University of Illinois. There are 71 individuals like this at NCI cancer centers from around the country. Now, there's not an NCI cancer center in every state. We know that. Louisiana, there's not one. But what we would like to do is, since NCI comprehensive cancer centers have community outreach leaders, what we look to do is to partner with them to actively reach out, and they actively reach out to community-based organizations, faith-based organizations, senior centers, and community centers. And they have networks to be able to reach patients, to engage them, to have better access to care, access to clinical trials, and other aspects that are important for education for cancer. And we've been reaching out to these community-based organization leaders who have these networks, and we're partnering with them. And we know this is going to work because in March of this past year, we launched a national COVID-19 Breathe Easier emergency fund, which was to help lung cancer patients undergoing treatment, help them with their finances. So Andrea turned to me and said, how do we get this program to all the patients? And I reached out to these 71 community outreach leaders, and they got the program to all the patients who needed it. So we know partnering with individuals who are in communities, who engage those communities, are going to matter. So our decision is to partner with NCI Comprehensive Cancer Center leaders who do community outreach to reach vulnerable populations and deliver patient-friendly education. And we plan to develop education for patients with them. Next slide. One other thing that it's important that we do is to continue to work with multiple stakeholders to build sustainable and impactful models, both locally and nationally. And this is what I mean by models. So on the left, there's an infographic of a publication that answered the question, what do cancer centers do who are able to engage racial and ethnic minority populations with success in clinical trials? Oh, I'm sorry, on the right, that's where that infographic is. And we identified 8 cancer centers in the United States who are able to accrue racial and ethnic minority populations up to 40% of the time, 4-0. And we asked them what they do and how they do it. And that resulted in 2 publications. On the left, we also engaged experts to deliver a framework to address cancer care disparities with recommended strategies along and between the cancer continuum of care domains. And this publication was submitted just recently, and it was an invited paper. So our decision as a foundation is modeling behavior, modeling what works in lung cancer is really important. And we plan to deliver national models for lung cancer care with vulnerable populations that work. So next slide. So overall, what have I learned? So first of all, cultural humility is really important to have every day. And ongoing implicit bias training is critical. We all have assumptions. We were built this way based on who we interact with, our families, our friends, the media influences that. But what we need to do is we need to stop and think about how it is that we behave and what we say. And implicit bias training is really critical to help us to have cultural humility. I've also learned that there's hope for lung cancer patients, but they don't think so. Patient-friendly education is lacking. The way to reach the community is the community, and we must be expert in lung cancer disparities at a state, county level for each racial and ethnic minority group and low socioeconomic status whites to be able to address disparities and understand if we are successful or not working with healthcare providers and community outreach leaders. Also for the cancer continuum of care, we are going to focus our early efforts on early detection and screening and in treatment inclusion in clinical trials. So next slide. So all of our decisions and learning drove basically our initial strategy for health equity and diversity at the foundation. So our vision is to secure the trusted engagement and partnership of lung cancer communities to achieve health equity and equalize disparities for all. And this work is informed by what matters. And we will focus on goals with corresponding deliverables focusing on the community. We will address disparities and be expert on that data on disparities and also develop models. So next slide. So in the process, I've developed a new hashtag. It's called All Together Now. And I love this quote from H.E. Luckick, because it's what I stand for and how I engage, which is, no one can whistle a symphony, it takes a whole orchestra to play. Thank you.
Thank you both very much for those excellent presentations. So I do have a number of questions that I'd like to pose to you. You know, Jeannie, you have outlined something, great programs to reach these minority groups. Adrian, you have do it for the rare disease groups. And do you feel that every organization should have a position like yours at this time? We know it's all very important to get those numbers and inclusions for these communities up in all these trials.
Adrian, you want to go first?
Yeah, I think that more than asking organizations to commit to having an entire position for diversity and inclusion, I think organizations should commit to committing to doing more than simply an initiative, right? I think a lot of organizations come at the idea of diversity and inclusion with a, let's start an initiative to take our resources and get them to diverse communities, rather than saying, how can we meaningfully and lastingly engage diverse communities? The benefit of having a specific individual for health equity, for diversity and inclusion, is that it gets you there, because that person can say, how can I personally engage and build a relationship with diverse communities in order to, empower them and make sure that they are, leading the conversation. But I think realistically, it shouldn't be so much, should there be a position for health equity, diversity, and inclusion, but how can we make sure that any programs or, initiatives are more than just a seasonal event or just a one-time thing?
Mm-hmm. Mm-hmm.
I guess my answer to this question is, big picture is that in America, we will be a minority majority country in 2040. And we already are a minority majority country for people under 18 years old. So it's really critical that the work that we do in patient organizations reach and engage all the patients. And another aspect of this that's really important is that sponsors, donors, industry are really interested in this work. They are really interested in the fact that we as patient organizations have relationships and outreach, and we know how to outreach to patients, and they want to have better inclusion of patients, not only to benefit from innovations, but to be included in clinical trials. So I think the whole infrastructure is depending on us to do a better job in this space. And I think it's really important.
Mm-hmm. Mm-hmm.
And can I go off? Yeah, I think a word there was really important: infrastructure, we have to build towards engaging with underserved communities, and in such a way that it creates an inclusive space that draws underserved patient advocates and patients.
Mhm. And I think that both of you mentioned, although you may have employees that do this, but how you've utilized going out to partners at specific institutions that do that specifically and work on those programs, so that even if you don't maybe have the finances to have a specific person in your organization, there are groups that you can look to help you develop these kind of programs.
Yeah, I agree. I think that we need to start, there's one thing that I didn't mention is I hired a health equity intern. Her name is Ingrid Povianetti Rivera. She's originally from Puerto Rico. She's an MPH student at Jefferson University. And I hired her for number one, because I needed help. But number two is she asked me a lot of questions and she keeps me honest. And I would really urge everybody just to start. Hire a health equity intern, hire a health equity fellow to start to do environmental scans, understand what it is that you can do in this space, and make a decision to do something. You don't have to do all of it. You can just make a decision to start. And I think once you start with that type of approach, it really will help, and you'll see where it is that you need to go.
Mm-hmm. Mm-hmm.
Yeah, I think that diversifying staff and board is, I think, really necessary to outreaching to diverse organizations and institutions. Representation matters, and individuals being able to see themselves in organizations, I think, means more than anyone could possibly understand.
Right. That's true. Both of you, or one of you, mentioned metrics to gauge success. In my organization, I know that we are always challenged with this. So what kind of metrics are you using to gauge your success? And what are your gold standards?
It's interesting. My boss asked me that question a couple of weeks ago. So, we're looking to stand up a health equity council at the LUNGevity Foundation with partners and work with them to define our metrics relative to our goals and our work. But let me just say early on, it's process metrics. It's how many, cancer centers do we have partnerships with? Through their efforts, how has our reach been with respect to engaging vulnerable populations in our programs? And, how many of them have registered on the site and have downloaded new patient education materials? So that's early on. Long term, I do believe that we will have metrics to show that we have moved the needle on disparities in each major patient population that we consider vulnerable. And we'll have the data to show that.
Mm-hmm.
I think that, making sure that we are collecting data on who's attending our events, who the representatives are from organizations in our working groups, and really building benchmark goals that establish meaningful presence by underserved communities, I think, is really necessary. If we can keep track and follow through on our goals for increasing diversity, I think we can really make sure that going into the future that we not only recruit diverse patient advocates, but retain them, like someone said in the chat. Yeah.
Right. Yeah. Because yes, we do want to look at, there's a big focus when we're doing clinical trials, but we really need to move beyond that and just general care and management of these. I know that for us, we don't have many clinical trials, but just to have them being monitored at centers of excellence for rare diseases. When you're talking about a rare disease, it's much harder for those patients to get to those centers of excellence. And it could be insurance barriers or you know, they just don't, are not able to get the care that they need. And therefore, they're not included even just in regular studies.
Josephine, I want to comment on that because I'm just going to turn that question around a little bit. And, you know, I think it's our job as patient organizations to share what, if patients have accessibility to care and to what extent that they do.
Right.
And myself and our research head at the LUNGevity Foundation did a very simple overlap analysis last year that was presented at a meeting. And what we did is we pulled the data from clinicaltrials.gov, looking at non-small cell lung cancer trials and small cell lung cancer trials, mapped all the sites, and we looked at the degree to which African Americans and Asian Americans have access to those trials. Are trials placed where patients live? And the answer was shameful. The answer is no. So we have to publish and get that data out on behalf of patients to show the infrastructure that where they're placing trials, if they want diverse populations in their trials, they're not going to have those trials be accessible to patients because they're not placing them where they're located. And I don't care how many, you know, hotel rooms you pay for or how much travel you pay for, it's just not going to happen if trials are not where patients live. And we need to do a better job and show them that data.
Right, right.
And I think that we fundamentally have to create spaces for patient feedback and really follow through on patient empowerment. You know, I think a lot of times we look at the data and look at the metrics and forget the patient advocates' experience, forget the patient's experiences and stories. And if we really took the time to actually listen to patient advocates and to hear their concerns and the burdens of rare diseases on them, I think we could create a more equitable rare disease space.
Right, right. Oh, I totally agree. And obviously, also language barriers. You know, we need to be prepared for that and provide the materials and talk to them within their own communities in their own languages. And I think, you know, you have both provided an excellent model of how we as all organizations can increase this inclusion of research in our studies and making sure that these populations are covered, because we need to make sure that care is equitable across all groups.